طيب ماشي الحال، خليني أحاول ألاقي I don't know what's going on. Okay, so currently في 35 موجودين. That's good. So today I'd like to give you a talk, يعني almost like an introduction to headaches in children. Have you been exposed to this kind of discussion? Do you have any kind of background about migraines or headaches in children? ولا هاي أول مرة؟
لا دكتورة، أول مرة.
Okay, so لأنه it's a new topic for you. It's your kind of introduction to headaches and migraines in children. What I wanted to do, I'll share with you my PowerPoint presentation. I'll start by giving you an introduction to headaches in children, to migraines, and after the introduction, to the pediatric neurology clinic, it's actually headache and recurrent headache. So yes, children do have headaches. Children also have migraines, and it's a very common presentation. It's one of the most common neurologic symptoms in children, and without a rational, informed approach to each child, we'll be running around with these children without giving a diagnosis and without giving them relief. And if every time a child presents with headache, we go around doing multiple investigations and delaying the diagnosis of migraine, that means that we're not treating the patient and the patient continues to suffer through his headaches. So headache is very common. And when we see a child with headache or migraine, and even in adults, one of the primary concerns is to be able to differentiate a child with a serious secondary cause of headache from the majority of children who have a primary headache, such as migraine. So in headaches, so in adults or in children, headaches can be primary. And what we mean by primary is, for example, something like a migraine headache. This is called a primary headache. And headaches can also be secondary to an underlying condition. These secondary underlying conditions could be something benign, but could also be something very serious, such as an intracranial tumor, such as, for example, an intracranial or CNS infection, etc. Okay? So a thorough history and a good neurologic exam, usually a good history with a good fund of knowledge as a background, and a good neurologic exam are usually sufficient to make the distinction, to differentiate between a primary headache and a secondary headache. Sometimes we do resort to neuroimaging or CSF examination or other tests. Like, we have to be clinically informed before we go ahead with a lot of investigations for these patients. Then, as I'll be presenting later, if we just do investigations without being informed or driven by clinical knowledge and the patient's clinical scenario, we'll be running around in circles. So children can have headaches. Children can have migraines, just like in adults. In adults, عادة بنقول the criteria for migraine is 4 hours duration. Like in children, we accept a 2-hour duration as a criteria for the headache. So children are different than adults as far as migraine criteria, because we can accept a shorter duration of headache. In children as well, the headache can be, the migraine headache can be bilateral. بينما in adults, usually adults will have mostly unilateral headaches. So it's unilateral in adults. Okay? أكيد يمكن general information عندكم إنه الشقيقة usually is unilateral, but in children they don't have a very well described headache phenotype as they do in adults. So we can have bilateral headaches in children, we can have shorter duration in children. Photophobia and phonophobia, this is what makes it more likely to be a migraine in children. Children very commonly complain of a premonitory symptom. They may complain of having a fatigue. Very commonly, mom will say that he's had a fatigue all day, he's been drowsy, he's been irritable. أحيانا بتقول he looks pale, he's had face changes prior to the headache. So this is a very common scenario for mom to complain of these symptoms before the onset of the headache. They can also have nausea and vomiting, and it's usually relieved by sleep and throbbing in nature. So these are the components of your history when you'd like to differentiate between a migraine or a primary headache in children or a secondary headache in children. If the headache is associated with photophobia and phonophobia, if there is nausea and vomiting, if the headache is relieved by sleep, and if the child is able to give a description that this is a throbbing headache, then this is likely to be a migraine in that child. Okay? There are two major types of primary headaches in children. واللي هم migraine headache, and the second type is what we call tension type headache. In adults, there's a wider variety of primary headaches. And in adults, you can hear of cluster headache. You can hear of trigeminal neuralgia. You can hear of occipital neuralgia. بينما in children, the two major types of headache, primary headaches, are migraine headache and tension type headache. Tension type headache and migraine headache, there's not a clear-cut differentiation between them. They're more like a spectrum. لكن لما يكون في tension type headache, they are less likely to have photophobia and phonophobia. They are less likely to have nausea and vomiting. Tension type headache is more likely to be in the afternoon, like خصوصا بالليل, بآخر النهار, after school, after they come home from school, they start having the headache. عادة tension type headache is shorter. It is less severe. And it's more likely to be pressure-like than throbbing pain. And there's less likely to be the presence of a family history. So there's not a clear-cut differentiation between tension type headache and migraine headache. Like if the child complains of photophobia and phonophobia, in addition to nausea and vomiting, and a severe significant headache, then it is more likely to be a migraine headache. Like if there is a milder headache, no nausea or vomiting, then this is more likely to be a tension type headache. Okay? الحقيقة the differentiation between them, it's important to differentiate. Tension type headaches, usually they're not that long in duration. بينما migraine type headaches are longer in duration. They can last into adulthood. لكن أحيانا كتير, even a child with a tension type headache might revert into a migraine-like headache. Okay, and the clinical approach to treatment is very similar. Any questions up till now? Everything is clear to you up till now?
Yes.
Okay, excellent. Let me go ahead and start with our first case scenario, the first case. And after that first case, we'll talk about the red flags in headache. When should you suspect a serious underlying cause of headache? So this is our first history. We have a 12-year-old boy. He is previously healthy. Again, this is in italics and it's in red. In all complaints, سواء in adults, لكن specifically and especially in children, previously healthy children are very different differential diagnosis than a child with a previous underlying condition. Okay, so we always pay attention in our histories, regardless of what the child presents with, سواء كان headache or another pediatric complaint. We always pay attention to whether the child is a previously healthy child or a child with a chronic illness. It makes a big difference in the differential diagnosis. Now, this child is 12 years old, previously healthy, and he presents for evaluation of headache of 3 months duration. The headache is bifrontal in location. It is pressure-like, and it is quite severe. He's unable to do his homework. It's worse at the end of the day, especially school days. It's almost daily. And once it starts, it continues till he goes to sleep. The family history, the mother has recurrent headaches. Can you think of any red flags that we should be asking about for this child to rule out a secondary serious underlying cause? Is the family history a concerning aspect of the history, or is it a reassuring aspect of the history? When you hear that the mother has recurrent headaches, is this reassuring or is it concerning for as far as the secondary underlying cause? So this is a reassuring aspect of the history. It's good that the mother has a recurrent headache. Very often parents will come in without a diagnosis of migraine. لكن لما تسأل الأم, she tells you, yes, I have a headache, it's recurrent. لكن a lot of times parents will have various explanations or interpretations for why they have a headache. So maybe the mother never sought medical attention, لكن she does have recurrent headaches. إذا بتسألها بتقول لك, yes, I feel very tired, it's unilateral, it lasts for a couple of hours, باخد medication, or I think doctor, this is just exhaustion, or maybe she'll say it only happened when I have the flu, etc. So they often don't have a diagnosis of migraine. But many times parents will get a diagnosis of migraine after the child starts having migraines. They realize that they too have a migraine. Okay, so mother has migraines or recurrent headaches. This is most likely to be a primary headache syndrome, such as, for example, maybe a migraine. Okay, this aspect of the history is actually very reassuring. It tells us that this previously healthy child most likely also has a primary headache rather than a secondary headache. So this is reassuring that this is unlikely to be a serious underlying cause. Okay, worse at the end of the day, almost daily. So what would you like to do next? For example, would we like to ask about focal neurological symptoms? So there are no focal neurological symptoms, such as no speech changes, no, for example, gait alteration, no weakness, no diplopia, okay? So the patient does not have any focal neurological symptoms. Is this a good thing or a bad thing that there are no focal neurological symptoms? It's good. It's reassuring that the child has no focal neurological symptoms. Can you guys hear me still?
نعم دكتور.
Excellent. Okay. So is this child likely to have a primary or a secondary headache?
Primary.
Yes, it's likely to be a primary headache. When we examine this patient, خليني أضيفها هون, he had a normal neurological exam. This is also reassuring. Huh?
Yes.
Excellent. Exactly. So this is likely to be a focal, a primary headache syndrome. This is likely to be not due to a serious secondary underlying cause. So what are the red flags that we should look for in such a patient to make sure that the patient has no serious underlying cause? These are the red flags in headache, okay? A history of trauma. If you have an early morning headache or the patient is awaking from sleep from the headache, this is more serious. If the child has early morning vomiting, or if he has a headache with a Valsalva maneuver, يعني لما يشد حاله, لما يكح, when he sneezes, يعطس, with coughing, with straining in the bathroom, for example, this is a serious complaint because this is indicative of a possible increased intracranial pressure. Of course, patients with immune compromise or patients patients, for example, patients with هنقول ataxia telangiectasia مثلا هدول they are syndromes that you can look up just to familiarize yourself with these neurocutaneous syndromes. Like there are some syndromes in children, genetic malformations that make children more at risk for having tumors. Noonan syndrome مثلا. Okay, so if the child has an immune compromise, makes him more likely to have meningitis or CNS infection, or if the child has an underlying condition that is at risk for neoplasia. Child with an underlying condition like this is a red flag. This is when you should think of a serious underlying condition. Of course, naturally, if a patient has an abnormal neurologic exam, or if they have neurologic symptoms that are not characteristic of migraine, for example, having diplopia, okay, the presence of growth abnormalities, and the absence of a family history. So these are the red flags in headaches in children, and these should be the components of your history. لما تاخد history of the present illness for a child with headache, we should ask about these red flags to make sure that there is no risk of a serious underlying condition. So if you take a very good history for the patient, you take a good description of the headache, أخذت good description of the headache, including all of these features, and you ask about red flags in the history, and you perform a good neurologic examination, you should be able, without any further investigations, to be able to differentiate between a child who has a secondary underlying headache or a child who has a migraine or primary headache. Any questions up till now? Okay, so this child this first case that we discussed has no red flags. He also has a positive family history, normal neurologic exam. So this child likely has a primary headache, and there's really no need for further investigations. There is no indication for example, an MRI of the brain or a CT of the brain if we're able to take a very good history and a very good examination. Okay? طبعا remember إنه لما نحكي normal neurologic examination, remember that you always should check the fundi in a child with headache. So children who present with headache to the clinic, هذول الأطفال, we always do a fundoscopic examination. If you are unable or don't feel confident in your skills for fundoscopic evaluation, you can always call a consult or ask a ophthalmology resident to check the fundi of the patient, okay? To check for papilledema طبعا. Any questions? So remember, always, as a rule, سواء كنت medical student or you are a resident or even at my stage, if there is something that I must do with the examination that I need to do, that I don't feel confident doing, يعني أحيانا أنا بالعيادة I'll do a fundoscopic examination, لكن في normal variations that sometimes I can't recognize. So if I see something strange and I'm not sure what it is, I always send the child to the ER أو على عيادة العيون to get a formal, good fundoscopic examination. And I don't consider that I'm done with evaluating the patient until I get that information, okay? So don't always know, it's important to know what you need to do and what you need to examine in patients. And sometimes if you can't do it yourself, it's always okay to send the patient out to do it somewhere else, okay? هاي كتير مهمة تتذكروها always. but you need to know that you have to do a fundoscopic examination. If you're able to do it, excellent. If not, ask someone else. Okay, خلينا نشوف this history. This is a 10-year-old, new onset headache. It's all over, moderate in severity. He has a runny nose. It's 1 week duration. There's no history of trauma. He also has a low-grade fever. He complains of ear fullness, a dry cough, especially at night. Meningeal signs are negative, واللي هي knuckle rigidity, Kernig's, and Brudzinski. تعرفوا meningeal signs, right?
Yes.
Yes. So meningeal signs طبعا are a skill that you must have. Again, when a child presents with emergency department with headache, you have to check for meningeal signs. And if you are unable or forgot أو نسيت كيف تعملهم or don't feel confident, it's always okay to either check or have someone else help you with them. Okay? But always remember to perform meningeal. ونادينا له بالطوارئ العيون, and they checked for papilledema and it's completely negative. Okay? هلا, does this sound like a primary headache, migraine, or tension type headache?
No.
No, because
No secondary.
it sounds like a secondary headache, not a primary headache. أول شيء عندنا very short duration. This is a new onset headache, صح? This is a new onset headache. So unlikely إنه يكون a primary headache. مع إنه it could be the first event, صح؟ ممكن يكون هذا the first migraine. لكن there's also fever, remember, صح? He has a runny nose, okay? It's all over and it's daily, continuous. What is the commonest cause of secondary headache in children in the emergency department? Actually, it is an upper respiratory tract infection. So in the emergency department, the commonest cause of acute headache in children is an upper respiratory tract infection. And as you can see, the child does have a dry cough, he has a runny nose, he has a low-grade fever, he has no alarming signals. Yani when we looked for meningeal signs, no papilledema, no vomiting, no morning headache, all of the red flags that we talked about, they're all negative. Do you think we need to do much else with this patient or just treat his upper respiratory tract symptomatically?
Just treat him symptomatically.
Yes, exactly. There's no need for further investigation in this child. Everything is normal. And you always have the option of having the patient come back for re-evaluation. مثلا بالعيادة a week later تقول لهم, they can be given symptomatic treatment such as بخاخات, a nasal steroid, maybe is an ENT, they might want to give him antibiotic if they feel he has a sinusitis. And then of course احنا ما بنحكي للمريض خلص روح. We tell them to go home and then come back for follow-up. Like at this point, there's nothing alarming and no red flags with this patient, okay? هلا this patient, unfortunately, لما اجى على الطوارئ قرروا يعملوا له CT scan. عملوا له CT scan طلع في عنده abnormality. What is this abnormality? This is an arachnoid cyst, okay? Arachnoid cyst. It is an incidental finding. It is not serious, does not cause headache. Anybody can have an arachnoid cyst. Like, unfortunately, this patient, when he was evaluated in the ER, they found this arachnoid cyst. حكوا له في عندك كيس ماي. The parents, of course, they became extremely anxious, very worried. حولوه على neurosurgery, حولوه على neurology. He did not get treatment for his sinusitis. They were all thrown into this dilemma, and eventually the patient didn't even get treatment for his underlying problem. So this is what happens when investigations are not guided by the history and the physical examination. There is no such thing as doing something احتياط or doing something just to be sure. And when you do this, when you feel that the patient there's no indication for a scan, it does not mean that you will do a scan راح تطلع normal. You might end up with a scan that looks like this, okay? طبعا eventually the parents, they were reassured. We had to get an MRI. We reassured them that this is an arachnoid cyst. It's congenital, it's incidental, it's asymptomatic. No further treatment is warranted. All right? Actually, children with migraine and patients with migraine may have white matter abnormalities in their MRIs. فبالتالي when you have a child with migraine or an adult with migraine and they present to the clinic, if you decide to do an MRI or if an MRI is deemed necessary, actually the MRI may be abnormal. يعني احنا we had a child maybe a month ago who presented more than a month ago صار معطلين شهر بس recently he presented with an abnormal MRI and a typical history of migraine, and his mother had migraine. طبعا his MRI had the typical white matter signal abnormalities that are seen in migraine patients. لكن طبعا they were worried, قالوا لهم maybe this is multiple sclerosis, etc. So always be judicial, always have good justification before ordering investigations. You have to have confidence in your clinical approach and in your clinical evaluation and your fund of knowledge. Okay, خلينا نحكي عن هذا المريض. Last thing, لأنه I want to introduce you. This is a 6-year-old episodic pallor, dizziness, بوقع. أمه لما صورت الإيفنت, he had nystagmus over the last 5 months. His older brother, father, and aunt all have migraines, and his exam is completely normal. So this child has what we call the episodic syndromes in children that are related to migraine, لكن they present without the actual headache. مفهومة هاي القضية؟ So
إيش الفرق بس؟
In children, these patients do not have any headache, لكن they have a migraine. So it's quite confusing, صح? This child does not complain of headache, لكن بصير في عنده episodic vertigo, okay? هلأ هو عمره 6 years old. Episodic vertigo, usually as they grow older, هدول episodic syndromes, they progress and evolve into a typical migraine. ماشي الحال؟ So children
دكتورة
who have, yes.
الحين لما يجيني الطفل أنا كيف أعرف إنه هذا مايجرين يعني من الفاميلي هيستوري؟
No, from the description, أول شيء, you take a good description. Nausea, vomiting, photophobia, phonophobia, relieved by sleep. Very typical for migraine, صح?
تمام نعم.
History that is typical for migraine. In addition, إنه لما تدور على red flags, you look for red flags, you find no red flags, okay? So everything is reassuring. In addition, إنه الطفل في عنده family history. So this is how you make the diagnosis that it is most likely to be a migraine headache.
طيب يعني دكتورة بالكيس الأولى عنا مايجرين ولا تنشن هيديك؟ يعني هي في فاميلي هيستوري بس ما في فونوفوبيا وفوتوفوبيا.
That's true. زي ما حكينا إنه هم yes, this could be a tension type headache. مع إنها الأم she has a recurrent headache. بس this could be a tension type headache. زي ما حكينا هم المايجرين والtension type headache are a continuum. يعني أنت with tension type headache you're less likely to have photophobia and phonophobia. And with migraine you are more likely to have photophobia and phonophobia. Children or adults who have tension type headache, sometimes they progress and the headache changes with time, بصير more like a migraine. So yes, this could be a tension type headache, مزبوط كلامك, because it's almost daily, mostly at the end of the day. No migraine variants in children, okay? So what is unique about children, they may have migraine phenomena without actual headache or head pain. So without pain, okay? Which can be, of course, confusing. And how can we say migraine when there's no pain? لكن طبعا remember in the migraine, if you think about, for example, aura in migraine, such as, for example, flashing lights or visual phenomena. So aura, there's no pain, صح ولا لا? So you may have, with migraine, you may have neurological deficits without the actual head pain. And this is unique to children, okay? They may have migraine phenomena without the actual head pain, okay?
دكتورة ممكن تعرض سلايدات مو موجودة لنا.
نعم.
سلايدات مو موجودة، مو معروضة.
I see. Yes, I have to share them again. يلا لحظة. Share screen and good.
تمام.
Okay. كم واحد صرنا هلا رجعنا؟ اوكي ممتاز. الماجورتي رجعوا مرة ثانية. So episodic syndromes are a unique situation for children where they might have migraine phenomena without the actual head pain. The most important, the most common are benign paroxysmal vertigo, which looks like this, okay? It's actually vertigo. The child looks pale. He feels like he's going to vomit. He's dizzy. أحيانا ممكن يصير عنده nystagmus. There's no loss of consciousness usually, okay? طبعا it's very helpful when you have a history of migraine, family history of migraine, okay? So this 6-year-old لما يصير عمره 12 سنة, for example, this benign paroxysmal vertigo will start to disappear and will be replaced by typical migraine phenomena, okay? Benign paroxysmal vertigo. The other episodic syndrome that's quite common is episodic torticollis. So these patients will have torticollis. You know what it means? Neck flexion to one side. Okay, this is called torticollis. ماشي. سامعين كلمة torticollis? Do you know what it is?
لا.
لا دكتورة.
It's kind of a dystonic posture. Torticollis. Actually, with pediatrics, let them start what torticollis is, because there's congenital torticollis that's sometimes related to congenital malformations. Sometimes it's related to, congenital fourth nerve palsy. So torticollis, I want you to look it up, تطلع على صور لإلها, and familiarize yourself with the term torticollis. Okay, you should know it. ماشي. It's neck flexion, abnormal neck flexion to one side. It's kind of a dystonic posture of the neck, okay? So these infants, عادة بتصير هي عادة بالinfants, infantile episodic torticollis. So they have episodes of neck flexion to one side. بتعجرة بتعجها, they might stay for maybe 2 or 3 hours and then it resolves. And episodic, تتكرر. Again, a family history of migraine would be very helpful, right? To differentiate, and this is likely to be a migraine phenomena. Infantile colic command, it's some believe it could be a migraine phenomena. And another very interesting condition is cyclical vomiting. هذول الأطفال, they have severe vomiting over 2-3 days. All investigations are normal. بيروح على المستشفى, بشوف الدكتور, بيجيك صار عامل تنظير وعامل all kinds of investigations. Everything is negative. Cyclical vomiting, one of the pediatric migraine episodic syndromes. Okay? So high topic, it's a bit tough. I can understand that, a bit new, or even the whole concept is difficult to grasp, and you can have migraine phenomena without the actual headache. But what you need to know in the children, this is what's unique about pediatric migraine, and they can have these episodic syndrome that are considered migraine, okay? And هذا الطفل presents to the clinic, we treat him as a typical migraine patient, okay?
دكتورة بس شو يعني infantile colic؟
سامعيني? Can you see it now?
لا باقي.
No?
لا.
I have to share the screen again لأنه we lost the connection. Okay. Can you see it now?
Yes.
Okay, excellent. So I'm gonna, when I do this, can you still see the PowerPoint? Hello.
أيوة باقي موجود الباوربوينت.
So you can see the PowerPoint still?
نعم.
Okay, excellent. I think I might have an article about migraine, about these that I can try to share with you. I can try. Head tilt. Okay, head tilt. That's a good expression. Head tilt, okay? To one side, ماشي? And infantile colic, يعني زي excessive crying. Well-fed infant, normal exam, okay? Excessive crying. This is what we call infantile colic. ماشي? Any questions so far? أهم شيء, do you guys have a good grasp of what migraine sounds like and looks like?
Yes.
And do you have a good grasp of the red flags and headache?
Yes, we do.
Okay, excellent. حكينا عن the most common cause of acute headache in children is an upper respiratory tract infection. Okay. The meningeal signs, you all know them, خصوصا when we have fever. Okay. وحكينا كمان عن ال pediatric episodic syndromes, يعني unique syndromes. يعني you don't have to know too much about the pediatric episodic syndrome, but you have to be aware إنه children sometimes with migraine, they may not present with the typical headache. Okay?
Okay.
يعني I'm trying to familiarize you with the unique aspects of migraine in pediatric population. Okay? هلا في two headache syndromes that are related to intracranial pressure. I'm not sure whether is it too much for you to go ahead and talk about those two situations. Should we go ahead? Maybe you can grasp some of it.
Yes, دكتورة, sure.
So this is خلينا نحكي عن هاي المريضة. She's 8. 2 months of headache, once weekly. She has episodic blurring of vision that lasts for a few seconds. This is what we call transient visual obscurations. Obscuration يعني غباش, right? Transient visual obscuration, okay? She does not have the typical migraine symptoms. ما في photophobia, ما في phonophobia, no nausea, no vomiting. Her family history is negative for migraines. So إحنا already now, we have something to worry about. مريضة?
Many red flags.
Yes, يعني إحنا typical history تبعت المايجرين, we can't hear it, صح؟ ما بنلاقي typical history قاعدين. ما في إشي typical for migraine. In addition, there's no family history. Additionally, she has these episodic blurring of vision, okay? And she has bilateral grade 2 papilledema and a left-sided 6th nerve pulse. So we have many red flags in this patient, صح?
Yes.
Excellent. Transient visual obscurations are actually typical for increased intracranial pressure, okay? Typical. When you hear someone who has transient visual obscurations, we should think of increased intracranial pressure. So, do you think this patient needs further investigations?
Sure.
Yes. Would you like to do imaging?
MRI.
Excellent. MRI of the brain. Always preferable to CT scan of the brain, okay? In children, when we are worried about a tumor, what are the commonest tumors in children? واللي هم posterior fossa tumors, okay? Such as, for example, a medulloblastoma. CT scan of the brain has very poor resolution for the posterior fossa. ما بنقدر نشوف posterior fossa with CT scan of the brain, okay? There's a lot of bone, very poor resolution. So we always need to do an MRI of the brain, okay? عملنا لها MRI of the brain, and it is normal MRI of the brain. So what do you think? Does she have increased intracranial pressure or not? She has 6th nerve palsy, which is typical for increased intracranial pressure. And she has transient visual obscurations, and she has papilledema. So she does have increased intracranial pressure. صح ولا لا?
Yes.
Yes, لكن her MRI is completely normal. أو خلينا نحكي MRI قرأ المقيم بالليل الأشعة وقال I don't see anything بالMRI of the brain. It's normal. ما في mass lesions, ما في hydrocaph, okay? So what I'd like to introduce you to today is idiopathic intracranial hypertension أو اللي بنحكي له pseudo tumor cerebri. سامعين فيه؟
لا.
No. Okay. Well, so we'll introduce you to it today. You will very likely hear about it لما تروحوا على النورولوجي ولما تروحوا على الجراحة ولما ترجعوا على الأطفال بالباطني. It's not uncommon, and you should always be aware of idiopathic intracranial hypertension. بنقول له pseudo tumor لأنه it sounds like the patient has a tumor, صح? There's increased ICP, 6th nerve papilledema, visual obscurations, papilledema, 6th nerve, 4th nerve, normal imaging, okay? So this is what we call pseudotumor cerebri. هلا the etiology, the underlying cause of pseudotumor cerebri is not very clear. لكن it is considered that there is poor absorption of cerebrospinal fluid. Okay? No mass lesion. We always have to do an MRI with an MRV because to rule out cerebrovenous thrombosis. Okay? Cerebrovenous thrombosis can present with intracranial hypertension. Usually with MRI, there is no mass lesion, okay? It is not a benign condition. فرح خلاص, I'm giving a session, اسكتي. It is not a benign condition. زمان, we used to call it benign intracranial hypertension. However, now we call it idiopathic intracranial hypertension. لأنه prolonged papilledema can lead to optic nerve atrophy and blindness, okay? So diagnosis is very important. If it is missed, papilledema, swelling of the optic nerve lasts for many months, the patient will lose vision because of optic nerve atrophy, okay? The diagnosis of idiopathic intracranial hypertension, هلا عملنا له MRI, ما في شيء. How can we diagnose it? We have to do, okay, with opening pressure. Have you ever, يعني بتعرفوا إنه في شيء اسمه opening pressure باللمبر pressure?
برضه لا.
Okay, هي عادة اللمبر puncture يعني اللي فيكم مثلا gets a chance. احنا عندنا بنجيب ال LP needles لحالها, بس هي عادة بتيجي with a kit, an LP kit, okay? بيجي معها a manometer. خليني أحاول if I can find a picture of it to share with you. Can you guys still see the PowerPoint? What can you see right now?
PowerPoint.
Okay, manometry. هلا بدي أشوف لكم if I can find the picture to copy and paste عشان تشوفوا كيف شكلها. This is how it looks like. هلا بعمل لكم copy. Hi, let's have a new slide. So this is what the manometry looks like. This is your LP needle, okay? وبيجي معها a manometer بيكون شفاف وبيكون مدرج. Okay. This is a three-way stopcock. يعني أنت بتقدر تمرق الفلويد to the outside for collection أو بتخلي الفلويد إنه يطلع through the manometer. So usually what we do إنه at the beginning before we take any fluid بيكون هذا مسكر من هاي الجهة ال three-way مسكر. فبس توصل للسي اس اف ببلش السائل يطلع through the manometer and we measure how high the CSF pressure is, okay? Normally it is between 12 يعني and 20 centimeter water. Above 20 it is considered increased in, okay?
اوكي.
This is let me see if I can find more imaging. ما فيش كتير له صور شكله. بس it is يعني standard actually. يعني إذا in any type of exam situation it is standard. يعني anytime you do as an LP, an essential part of the lumbar puncture is to measure the opening pressure before you collect the fluid. Okay. Unfortunately إحنا ما عندنا هاي الكيتس. يعني عندنا manometers that we use when we suspect patients with increased ICP. لكن it's not routine for every patient. Okay. هاي كمان copy image. كمان this is how it looks like, okay? Can you see this?
ايوه دكتوره.
So this is the stopcock. هياته زي ما انتم شايفين شفاف ومدرج. It is connected to the needle and before we take any fluid بنخلي الفلويد يطلع through the manometer to measure the opening pressure. يعني أنا مثلاً I trained in the States. You would never ever do a lumbar puncture without measuring pressure. And when you write your LP procedure note, the first thing you mention is the opening pressure, okay? Like, this is unfortunately not what you will see practiced عنا. We don't have those kits, okay? مفهومة هاي القضية? Any questions about it? So idiopathic intracranial hypertension is elevated opening pressure on manometry with a normal MRI of the brain, no mass lesion. This is what idiopathic intracranial hypertension is. Pseudotumor cerebri. They have edema, they have 6-nerve palsy, they have increased ICP, like no mass lesion. They have impaired absorption of CSF. Any questions on idiopathic intracranial hypertension? And I think at this stage, if you just familiarize yourself and there is such a condition, maybe you can read about it today, something brief to consolidate it in your brain. It would be very good. This is something that you need to know about, okay?
طب دكتور شو فرقت عن اللي قبلها هسه؟
فرقت عن ايه؟
عن الترانزيانت فيجوال شيء.
Transient visual obscuration is a symptom of increased ICP. They are a symptom. Okay, so in patients who have idiopathic intracranial hypertension, transient visual obscurations are a common symptoms. Okay, papilledema, 6th-nerve palsy, 4th-nerve palsy, and TVOs. Okay, so patients with idiopathic intracranial hypertension, they have transient visual obscurations as a symptom. يعني قبل يعني السنة عندنا مريضة لهلا بنتابعها. She presented زي هيك. بيجيها a few seconds up to 20-30 seconds every day where she has blurring and loss of vision and return of her vision. Okay, this is what we call transient visual obscuration, and she has pseudotumor cerebri. جاوبت على سؤالك؟ نشوف الفرق بينهم؟
دكتورة شكرا.
Okay. Any other questions عن هذا الموضوع? I know it's a bit maybe unfamiliar, maybe a bit tough, but it's something that you should know about actually. You know, expected after you're done with 4th year to know what idiopathic intracranial hypertension is. Okay. Any questions about it? فاهمين منيح؟ It's a good idea زي ما حكيت لكم يعني I gave you this introduction today. It's a good idea to read ولو even a brief paragraph about it. It will really consolidate and you can understand it better. Okay. We treat these patients عادة medically with acetazolamide because it reduces, it's an ACE inhibitor, and it reduces the production of CSF. In severe cases, we might even need to do a VP shunt or optic nerve fenestration. بيعملوا زي, you know, cuts in the optic nerve sheath to relieve the pressure around the optic nerve. Okay? Move on.
تمام.
So this is the first pressure-related headache, واللي هي idiopathic intracranial hypertension. The second pressure-related headache هو العكس, when you have intracranial hypotension. Okay, low CSF pressure headache. ماشي؟ هذا low CSF pressure headache أهم شيء تتذكروا إنه it can happen after LP. ماشي؟ After lumbar puncture. أحياناً if you have a big needle إذا كان اضطروا يروحوا يجوا أكثر من مرة, sometimes the patient will have a CSF leak. Because of that leak, the CSF intracranial pressure is low, and this will lead to a headache. Okay. Additionally, epidural analgesia, يعني this headache is common after delivery, and the الستات who deliver with epidural analgesia, after delivery they can have a significant low CSF pressure headache. ماشي الحال؟ أحياناً post trauma طبعاً you can have a CSF leak. Okay. أحياناً هذا الليك بيكون from the nose. أحياناً we can see, we have to do contrasted imaging of the spine. Okay. هذا الهيديك characteristically it is worse in the upright position. يعني المريض بيوصف very clearly إنه لما يكون متمدد he feels fine. Immediately upon assuming the upright position they immediately have a headache. وبس يتمدد برجع الهيديك هذا بخف. This is characteristic for low CSF pressure headache. What happens إنه لما المريض يقعد أو يوقف, the brain because of low CSF pressure it sags, بنزل لتحت. Okay. فبصير tension or stretching of the dura mater. This is the cause of the headache. ماشي الحال؟ هذول they do have يعني typical findings on MRI. بنطلع بنلاقي عندهم meningeal enhancement. You see هون this is an MRI with contrast. شايفين هذا الأبيض هون هيك, this and this and this. These are the meninges and they are enhancing. Okay. هاي أهم finding عنهم إنه they have diffuse meningeal enhancement.
يعني تصير ثكر.
نعم.
تصير ثكر يعني.
Yes, because they are a bit thicker and they're enhancing because there's a little bit of kind of an inflammatory reaction because they are stretched. يعني every time epidural analgesia very suggestive, and then the typical headache is worse in the upright position. مرات بيجي الطفل you know with meningitis نعمل له LP, الحرارة بتنزل, complaining of a new headache, a severe headache. Okay. And it is a post LP headache. Okay. فلما نسأل أسئلة and it is always in the upright position بعد ما نعمل له LP, so we know this is post-LP headache rather than, for example, an epidural abscess or a collection. Okay? Treatment عادة we manage them, we ask them to have more fluids, caffeinated beverages, caffeine is excellent. In severe cases, في شيء اسمه blood patch, they take a sample of the patient's blood and they inject it in the CSF, okay, in the epidural space. Okay? حاول أدور على الباوربوينت. Patients most at risk لل pressure related headaches هذول low CSF pressure.
دكتور الباوربوينت راح.
اوكي هلا بنرجعه. ايش بيروح مرات. share screen. رجع؟
تمام.
Okay, and remember we talked about always taking history from patient whether they're previously healthy or not. يعني for example, if you have a patient with a connective tissue disease such as Marfan syndrome or Ehlers-Danlos, هذول الديورا ماتر تبعتهم are more likely to tear, تنمزع أسرع. They are at higher risk of having a low CSF pressure headache and a CSF leak. Okay, so a leak of CSF can lead to a low CSF pressure. بالعكس لما يكون في عندنا reduced production, reduced I mean absorption of CSF, you will have an intracranial hypertension. هذول هم the two pressure related headaches اللي حبيت أحكي لكم عنهم اليوم. Okay?
Okay.
Any questions? I know شوي maybe زخمة lecture, but I think these are all concepts that you must be يعني familiar with. I hope يعني I've been able to familiarize you with them. Or like I said, if you read a paragraph about each of these conditions that we talked about, it would be extremely helpful for you to consolidate the information in your brain. Okay? Any questions? I can upload this lecture for you if you'd like on e-learning.
يا ريت دكتور.
Okay. ماشي. Good luck. يعطيكم العافية.
الله يعطيك العافية.